All right. Thank you so much. So again, hello for everybody who's just joining. My name is Alida, and this talk is called Bending, Not Breaking on Resiliency and Treatment-Resistant Depression, Autism, and ADHD. And of course, now my slides won't navigate. There we go. So hey, yes, I'm Alida. I'm a software engineer at GitHub, and I have panic disorder, ADHD, autism, and treatment-resistant major depressive disorder. I want to keep this talk fairly informal and as brief as possible for somebody who does not know how to stop talking. But today, my goal is to cover what makes depression treatment resistant, how I experience treatment resistant depression, how do you treat something that has treatment resistant even in the name, where my autism, ADHD, and treatment resistant depression overlap. So again, because I know this is sort of a newer term, if you hear someone talking about neurodiversity or neurodivergence, it's talking about individuals with different neurotypes, such as those who are uh, ADHD or on the autism, like have autism spectrum disorder, things like dyslexia and dysgraphia. I'm also going to talk a little bit more practically about navigating work and life with these diagnoses, and I'm also going to provide some sources and resources at the end via a public document that you can share with anybody who you think might need it. Um, I'm going to be very frank and vulnerable in this talk because I think this kind of material needs that level of vulnerability and humanness. And one of my personal missions is to make talking about mental health openly a normal, super mundane thing. As you see on this slide, there is going to be a very brief, non-specific mention of self-harm and suicide from a clinical lens. No talk about experiences or anything more detailed than just the words, but I wanted to get that out at the jump in case people have boundaries that they need to enforce for themselves. All right. So let's start with what is treatment-resistant depression. So treatment-resistant depression is a subset of major depressive disorder, which doesn't respond to traditional and first-line therapeutic options. Now, if you're lucky enough to not know major depressive disorder quite well, or if it's perhaps like something different in your life, I'm going to talk a little bit about what major depressive disorder looks like, so you can get a sense of where we're going from here to something that's treatment resistant. So as it says on the tin, treatment-resistant depression is a subset of major depressive disorder, which does not respond to traditional and first-line therapeutic options. So this is a syndrome with lasting sadness or emptiness emotionally. Someone may experience a loss of interest and enjoyment in anything, whether it's work, hobbies, social interactions. They may experience appetite and weight changes. They may also experience things like insomnia or hypersomnia, so either sleeping too little or sleeping a lot. They may be agitated or restless, or conversely, they might be feeling, thinking, and acting slower than usual, almost like they've been literally slowed down. They may have trouble concentrating or making decisions. They might feel guilty or worthless. And they may experience suicidality or self injury, such as like suicidal thoughts or intent, whether that is something they're actively choosing to think about or something that is passively or intrusively occurring for them. There isn't really a consensus in the medical community itself for a single clinical definition of treatment resistant depression, but it's generally diagnosed when a patient who has a diagnosis already of major depressive disorder has an inadequate response to at least two different trials of antidepressant medication therapy, usually from two different kinds of antidepressants, but not always, and one course of standard psychological talk therapy. It's worth noting that we all experience varying depressive symptoms as part of a normal human behavior and in response to expected stress or triggers like grief. However, in the case of clinical depressive disorders, these experiences either extend well beyond someone's like expected triggers or exist without inciting events at all. Generally, oh, Um, generally almost 70% of people diagnosed with a depressive disorder experience significant remission or like relief from their symptoms within about a year and a half. Of the remaining 30%, about half of those folks remain significantly symptomatic for greater than 2 years. Basically, not everyone who has depression responds to traditional antidepressant therapy, and the longer someone experiences chronic depression, the lower their chance of recovery becomes. For me, this basically means that traditional methods of treating depression, like antidepressant medications, of which I've tried with no hyperbole, north of 10 combinations now, lifestyle changes and therapy haven't caused any real improvement or remission of my depression symptoms. Subsequently, I've been working to manage my chronic depression for about 5 years now without relief. Depression impacts about every aspect of my life and how I approach myself and others, daily functioning, my mood, physical energy, and my ability to work and engage in hobbies. So, as you can imagine, this is something that is so ingrained in my everyday that I almost don't even think about it, but it really just super impactful, and when it's difficult, it's really difficult. Which brings me to what you can even do for something like treatment-resistant depression, because what I just described doesn't necessarily give you a lot of hope and fuzzy feelings, I imagine. So, currently, there are a few different types of treatment for treatment-resistant depression. There's what's called additive pharmacotherapy, which is when you augment already existing antidepressant therapy with a secondary medication. These can be things like lithium, triiodothyronine, or antipsychotics like Abilify or Seroquel, which are shown in low doses to have a complementary effect to antidepressants. There's non-medication options like brain stimulation therapy. These are elective therapies like repetitive transcranial magnetic stimulation. So basically, getting repeatedly zapped in the brain, um, and other forms of stimulation therapy involving like electrical medical equipment. There's also a category called novel therapeutics, which is when you use medication or substances not normally used for mental health. In this case, ketamine and esketamine, specific anti-inflammatories, and psilocybin are the most commonly used. Each approach naturally comes with both positives and drawbacks, not to mention stigma or legal implications, though that's outside the scope of this talk. Um, I'm personally actually undergoing ketamine infusions for my treatment-resistant depression once every 2 to 3 weeks as boosters after in May I did an acute treatment phase where I was going twice a week. Um, it's a low dose infusion of ketamine administered by an anesthesiologist, and it's either by IV, a tablet you melt under your tongue, or a nasal spray. I'm actually doing the nasal spray now. I've tried the other two, they didn't quite work for me. And it's what is referred to as a rapid acting antidepressant. It works on different receptors than normal antidepressants, which is why they try it for people who don't respond to regular depression therapy. So I mentioned that this talk is meant to examine not just treatment-resistant depression, but the intersection of this and other conditions that impact executive function, spoiler for upcoming content, and what it's like to navigate that intersection in particular. So as I mentioned at the beginning, I'm also autistic with ADHD, and I wanted to talk for a moment as how I experience this intersection. This part is based purely on my experience and not from a clinical perspective. Everybody's experience with uh, different neurotypes is different because we're all individuals. but wanted to give sort of my perspective. So I kind of think of this as playing the game on hard mode. The first and probably most impactful area of my life are challenges with executive functioning. So before I got my ADHD diagnosis in 2020, I actually considered myself a very strictly organized, structured person, despite anecdotes to the contrary from my parents about the state of my backpack or my closet, or if anyone has ever seen the desktop folders on my computer, I'm sorry. I learned through this process that the structures I relied on and that I enforced for myself were coping mechanisms to avoid basically being called out for not being very organized. And I overcorrected into hypervigilance and was actually making myself more anxious by being constantly on alert to for fear of ridicule for being messy. Um, Autism and ADHD both present unique challenges with focus as well, whether that be under or over focusing or inappropriate focus. It's not just that I can't focus on what I want to do, but sometimes I am so focused on what I want to do that I cannot tear my attention away for even things that you would normally get like naturally alerted to, like hunger. Another arena in which, as I apparently put it in this talk, my diagnoses duke it out, is self-image and emotional regulation. My thought process often jumps to assumptions about how others perceive me based on my own self-image, and I can spend a lot of time in thought spirals. And if you've ever had like a thought spiral, or you've been like spinning the drain, circling the drain on a particular thought or idea, and you just can't stop thinking about it, you're probably familiar with what this feels like. But it might look a bit like thinking, oh, like I need to do this task. I need to fold the laundry. And then there's laundry everywhere. So it's like, oh gosh, where do I start? And then I start thinking about like, I don't know where to start with this, and I feel overwhelmed. And then guilt comes in, and I'm like, I shouldn't feel overwhelmed by this because like I fold the laundry all the time. This should not be difficult. I don't even know how to ask my husband in this case, like, hey, can you come help me fold the laundry? Because it seems so rudimentary to me. If I ask my husband for help, he's going to think that I'm useless or that I don't care about doing the chores. And you can see how this starts to spiral into this like very negative pattern of how, oh, I need to fold the laundry is now I'm a failure and a complete disaster. The longer that I spin, and the longer that anybody spins, honestly, the worse you feel, right? So, with all of these in mind, I want to talk a bit about how I navigate my day while understanding all of these things about me. Because I've come up with some methods of coping and giving myself structure. It's not perfect, but I like to share. I have bad days more often than I'd like, and sometimes that aforementioned spiraling is really hard to interrupt. But here are some things that have worked for me. So the first one is external prompting. I really struggle with remembering rote tasks. Um, I don't really have habituation with my ADHD and autism. So I have reminders and notifications for everything from, hey, you need to take your meds, to dental hygiene, to, hey, you should probably eat some lunch, to work tasks. Because again, like without that habituation, I don't remember. And it's not that I don't want to remember, I just don't. Um, Sleep hygiene. It's not very exciting. It doesn't sound very fun, but it's super important, especially if you have issues with like delayed sleep phases, insomnia, um, circadian rhythm disorders. So I don't use screens late at night or consume anything terribly exciting after dinner. Um, Caffeine and I have gone from best buds to barely acquaintances, which would very much surprise me 10 years ago when I used to manage a coffee shop. Um, my bedroom is cool, dark, only for sleeping. I don't hang out in bed unless I'm sleeping, no matter how cozy. There's no TV in there. It's I bought a really cozy couch to compensate, but yeah, like my bedroom is so boring. And then I have a night routine, and because I need that external prompting, I have phone remembers and a written routine that I have, like, taped to my bathroom mirror that I can refer to, so I don't have to manually think about the steps. The next is something I call meeting myself at my own level. It's less a particular strategy and more of a mindset where I know that there are certain tasks um, or things that, like, if I don't give myself a variety of options of varying levels of accessibility, I'm going to struggle. Um, I know, for instance, that if there isn't easily available food, I will order takeout. I have some quick, healthy-ish options. I also meal prep on days where I feel better, and then I freeze those things. Also, just a reminder, food itself doesn't have a morality attached to it. Fed is best, so if takeout is where I end up, that's still okay. Likewise, I ensure I have a palette of options to choose from for hygiene. Yeah, this is a little awkward and uncomfortable to talk about, but not every day is going to be a good day. That doesn't mean I don't deserve to be clean. Sometimes it means a full shower, hairstyling, skin routine, the works. Sometimes that means a quick shower, dry shampoo, and compostable wipes. I know that there are certain stimuli as well that cause me sensory issues due to my autism specifically, so I make accommodations for those. Noise canceling headphones. I use loop earplugs in crowded public spaces to reduce the overall noise impact, like at the grocery store. I excuse myself regularly from busy social settings to take breaks from all of the social stimulation. I keep a pretty consistent and soft feeling wardrobe to help reduce decision fatigue around what I'm going to wear and to ensure I'm not constantly distracted by how my clothes feel. I never understood why, as a kid, I hated socks, but it's like the seam in socks drives me batty. Um, so I need socks that don't have those, as an example. And much like food, like, needing accommodations doesn't have morality attached to it either. Like, you shouldn't feel guilty for needing to meet yourself at your own level if it helps you be the kind of person you want to be, because you're not so occupied with not feeling good. Finally, I make space for rest. And um, Dr. Doctora, sorry, Dr. Sandra Dalton Smith promotes this theory that there are actually 7 kinds of rest. It's not just napping or sleeping in on a Sunday. So there's physical rest, mental rest, sensory rest, emotional rest, creative rest, social rest, and spiritual rest. I try to check in with myself often to see what kind of rest I need most and make that type of rest a priority. I hope this talk helped illuminate some of the more challenging aspects of chronic depression and introduce you to what long-term depression can be like for folks. As always, I think it's so important to talk about mental health and getting support. I've made this one of my personal missions, as I said at the beginning, for a very long time. And if I can help even one person feel seen, heard, and or supported, then I'm doing the right thing. If you're struggling, please reach out to a loved one or use a mental health resource available to you, whether that's through our through your company's benefits or like public benefits. It's okay to not be okay. It's okay to need support. Thank you.